Well, good afternoon, everybody. Welcome to our first session of COVID-19, Colorado and Beyond. This webinar is sponsored by the University of Colorado Denver's College of Liberal Arts and Sciences and its continuing and professional education and interdisciplinary studies programs. My name is Marjorie Levine Clark. I'm a professor of history and associate dean for diversity outreach and initiatives in the college. I will be your moderator for the series. All of you are here to learn more about the pandemic that has changed our lives on multiple levels. Just today, the New York Times reported that coronavirus cases hit a new daily record worldwide. We have watched the ways this global health crisis has overwhelmingly affected vulnerable populations. It has also created a global economic crisis with unemployment numbers like we haven't seen since the Great Depression. We're also facing a social crisis as people's realities have dramatically shifted in a very short period of time. As individuals move through the different phases of being shut in and slowly re-entering public spaces, we realize how difficult it is to negotiate the various choices that are offered to us. We weigh risks and benefits. COVID-19 is now intersecting with the tragic deaths of George Floyd and others, and the protests these killings have provoked. This interdisciplinary series will address these themes and more. Now to housekeeping. Please be patient. All the lectures will be recorded and made available on the CLAS YouTube channel after they are presented. You should have received the YouTube link in your reminder email for today, and you can find it on the Continuing and Professional Education website where you enrolled. Please use the Q&A feature at the bottom of your screen to ask questions during the lecture. We hope to have a healthy Q&A session at the end of the lecture. Some of our participants today are university students looking to transfer the lecture series into one course credit at the end of the webinar. In order to be eligible for credit, you must attend all the lectures or view the recorded videos and submit a response paper for every session. At the beginning of each lecture, I will give you a question about the lecture for which you will have to write a one-page response. You will be able to find this question on the website after the lecture. At the end of the webinar series, you will submit an online enrollment form and upload all your responses at the same time, indicating that you would like to be evaluated for credit. CLAS will cover the cost of the credit for the first 100 CU Denver students who request credit and turn in the response papers at the end of the term. You can find all this information on the website. Your question for today is, what is required for an epidemic to occur? Some of you are seeking professional development credit for attending the series. Continuing education units, or CEUs, are based on your attendance hours, so you must keep track of which lectures you attend to claim your CEU credit. Again, at the end of the webinar, you will submit an online enrollment form indicating your attendance hours and your desires to sign up for CEUs. There's an additional cost associated with this option. So before getting down to business, I have a bunch of people to thank for making this series happen. Dean Pam Jansma and Assistant Dean Joanne Porter of the College of Liberal Arts and Sciences for supporting our students. Our outstanding faculty who volunteered their time for this series. Mike Effler and Noah Dodero from the Office of Information Technology. Sheena Bull and the Office of Digital Education. Interim Associate Vice Chancellor of Academic Affairs, Joanne Brennan, the University Registrar, Carrie John and her team, Associate Bursar, Eric Gray, Tracy Combe, Director of Marketing and Communication in CLAS, Laurel Dodds, Director of Continuing and Professional Education in CLAS, Mary Lovett, Course and Curriculum Coordinator in CLAS, and finally, Kristen Salisbury, Program Manager in CLAS Continuing and Professional Education, who coordinated putting this whole event together under an extremely short timetable. Now we can get down to business. Our lecturer today is Dr. Jonathan Samet, Dean of the Colorado School of Public Health on the Anschutz Medical Campus. He received his medical degree from the University of Rochester School of Medicine and Dentistry and a Master of Science degree in Epidemiology from the Harvard School of Public Health. Dr. Samet is a pulmonary physician and epidemiologist. His research has focused on the environment and the lung, including air pollution, tobacco, and radon. He is leading the Colorado COVID-19 modeling group, which he says could be another full-time job. His lecture is titled The COVID-19 Epidemic, Epidemiology, Models, and Policy. Welcome, Dr. Samet.
Thank you very much, Marjorie. Let's see, let me get going with my screen. Let's see. So do you have the slideshow up now? Okay, I'll assume we do. So I'm happy to be here with you today to really kick off this series with, I think, what is a broad introduction to this epidemic. And I guarantee you, pay attention, by the end you'll have an answer to that tough question you have to answer if you want credit. So let's see. Okay. If you don't have, Marjorie, if you don't see starting with the basics in front of you, please let me know, and I'll have to do some technological adjustment here, but that's what I'm going to do.
You're all good. You're all good.
We're all good. Okay, great, thanks. We're going to start with the basics, and first off, let's start with the virus. Remember back a few months ago when you had never heard of the SARS-CoV-2 virus? If you're old enough, you remembered the 2003 SARS pandemic, where I think the world really dodged a bullet. What is a coronavirus? So they're called coronaviruses because they have spiky surfaces, like a crown. So that's why they're called coronaviruses. They're an RNA virus. So remember that a virus can have RNA or DNA coding its genome. So the purpose of a virus is to replicate itself. And in the case of this virus, it enters the body at some point, the nose, mouth, upper airway, and it binds to receptors in the lining of the lung and enters the cells and does its job of taking over the cellular mechanism to replicate itself. Down here, you can see the spikes on the surface that are in fact what it binds to a receptor site on the cells of the lung. We know that coronaviruses have been with us. They're one of the causes of common colds. There are 4 that cause about 1/3 of the common colds. But now we have 3 that don't behave well. The original SARS virus, the Middle Eastern Respiratory Syndrome virus, which is really communicated from camels by those in close contact with camels. And now we have this disease, COVID-19, caused by the SARS-CoV-2 virus. And for those who are making vaccines and working on them, the structure of the virus, its proteins, are critical in thinking about what are the targets for the antibodies that a vaccine would produce. Now, this is a complicated picture, and I'm just going to tell you what it shows. And it really illustrates the sophistication of how we can approach these viruses now. This is the sequence of different parts of the genome of the virus. So here is the genome for this particular piece, the receptor binding part. And here's another site on the genome. And then going down, there's different viruses listed. So the SARS-CoV-2 virus, a bat virus. You've probably heard about the pangolin now, a marsupial that is thought might figure into the jumping point from virus from animal to man, the original SARS virus, and viruses in bats, and these are in South China. So what you can see is that there are differences in the colors across these domains as you move from one virus to the other. So there's a lot of questions, of course, about where do these viruses come from, what was the reservoir, how did they jump from animal to man, And this sort of genetic coding story gives us insights into the origins. For example, how much of a change is there from this particular bat virus to the human SARS-CoV-2 virus? And the answer turns out to be not much. So quickly, with our modern techniques, viruses are sequenced. They provide us clues as to their origins, and they'll provide us clues as to potentially as to how to develop vaccines. So I think this helps in understanding its origins. It also helps in understanding some of the theories that may not in the end be credible, like this is a virus that escaped from the Wuhan virology facility. So lots of good science already in progress and literally thousands of papers published. Now, I'm an epidemiologist. Marjorie mentioned that, and sometimes epidemiologists, in trying to say what they do, tell the public, well, we're the disease detectives. And one critical good story for this outbreak is the story of Jon Snow. Now, this is not Jon Snow from Game of Thrones. Put that aside. This is Jon Snow, who was a physician in London. And among other things, he was intrigued by cholera. At the time in London, 1853, no one knew that there was a bacteria, the Vibrio cholera, that caused uh, an epidemic that caused cholera. What Snow did was to make observations about people who had cholera, sick people. And in one particular outbreak, he investigated others. He found that all the sick people had been using the same water pump. They went and pumped their water. The pump was called the Broad Street pump. And what Snow did is he inferred that since the sick people had all obtained their water from this pump, that the transmission of the cholera organism, although he didn't even know there was one, was through the water. So this is a great story of the application of the epidemiological method and the solution to an epidemic. Now, my point in telling you this story is that we use the same processes now with outbreaks. Here's a great book on the cholera epidemic and on what Snow did, the Ghost Map, a good read, since now's the time to read about epidemics. So what did Snow do? He identified the cholera outbreak, that there was an outbreak. He investigated the Broad Street pump. He inferred that water transmits cholera. And he said that the pump handle should be removed. He actually didn't do that himself. And then he watched. He continued tracking. And this is sort of the approach we take for outbreaks still. So we identify what the problem is. There's an outbreak of a new, mysterious, severe respiratory illness in Wuhan, China. And that emerged over December, as you know. Gather data and take a look at the data to interpret the evidence. And again, in this case, what did we learn? We learned that there was a new virus, a novel virus that had emerged. It was quickly sequenced, and we knew that it was a coronavirus. And then the question of moving from what we knew into action. And of course, that began in late December into January. And of course, over time, as the seriousness of the epidemic emerged, the pandemic emerged, we began to take more and more action. And then we move into surveillance. That means we're watching. That means we're counting the cases. We're counting the deaths. And I'm going to talk about what we do when we do surveillance. So moving on then, some definitions. An epidemic is when we have more cases than we expect. So here, endemic is a disease we usually have. So for example, for colds, we might always have some in the background and then perhaps have an epidemic of some new respiratory virus. In the case of the SARS-CoV-2 virus and COVID-19, certainly we have an epidemic we had none before, and now we have this global outbreak, and that global outbreak is called a pandemic. So a pandemic is simply a global epidemic, and this is the playing out over time. Now, one key characteristic of an outbreak that we look at is the epidemic curve. And again, I suspect that most of you have now heard the term epidemic curve. Epidemic curve is how the cases play out over time. So one place where we've had a chance to see the full epidemic curve is in the Diamond Princess cruise ship, which you remember stayed docked for quite some time, and it was possible, since all people on the boat were observed, to see what happened over time. So here we are. The ship sails back here from Yokohama around the start of January. Then we can see quarantine beginning. Here's cases. The orange are the passengers. Close contact with infected people, other passengers in the gray, and you can see the orange rising, then the gray following, and then the crew becoming sick. And you can see the decline, the rise, and the decline over time. One thing we learned from this epidemic was something called the attack rate. What percentage of people became ill? So it wasn't 100%. It was 19.2%. So this we would call the attack rate. Now, why not 100%? Most likely because of the quarantine measures taken on the ship to provide protection for those who were not infected. Certainly a challenging circumstance. One other characteristic of an epidemic, of an infectious agent you need to know about, is something called the R0. You may have heard of the R0, the reproductive number. What this number is the hypothetical, well, not the hypothetical, the number of new cases caused by an individual with infection. So here's a hypothetical infected individual, number A right here, surrounded by uninfected people. And this individual infects one other person. That's day one. And then day two, this person is still out and mixing, feels well, and infects 4 additional people. Day 3, this individual is at home, not feeling so good, and affects no one. And here this person is on their last day of infectiousness. They're bedridden, they're not feeling so well. Some relatives come by to visit, and one of them becomes infected. So you can see that this person has definitely infected more than one person. And if this value of R0 is greater than 1, then an epidemic can propagate. And if you look at this picture, here's a hypothetical outbreak where each person infects 3 more. And if you look at it, 1, so what happens? 1 person, 3 people, 9 people, 27, and so on. So you can see how an epidemic can quickly become out of control if R0 is very much above 1. And a lot of our infection control efforts have been to bring R0 down. Then finally, we're going to take a look at how do we measure disease. So here's some Colorado cases, and we're showing the cumulative number. So each day we're adding how many cases occurred on a particular day to how many occurred to date, until you get up here towards the end of May with about 25,000 cases total in Colorado. So here we're just counting the cases over time and accumulating from the start to the end of the time we are watching. Now, we also plot disease by place. And now I'm showing you Colorado with the case rates, the number of cases per 100,000 people in Colorado by county. So now we've taken the population out of consideration because we're taking the total number of cases in the numerator, dividing by the population at risk in the denominator. So even though some of these counties are very sparsely populated, we are taking population into consideration. And you can see how these rates vary around the state. Of course, they varied a lot over time as well, but this is the kind of approach we use to look at geographic variability. And then we look at the numbers of deaths. And again, this is the numbers of deaths in Colorado. And you can see the rise of the epidemic curve and its fall. Unfortunately, we've even had a few days with seemingly no deaths. It takes a while to get them all reported in. But here is an epidemic curve, the rise and the fall. And of course, what we want to do with all the steps we have taken and will take is to avoid a rise of this curve again. And just a little more data. We look at these counts and rates by age. So now on the bottom, we're going from 0 to 9 to 80 plus. And look at the colors. Deaths, the deepest blue, hospitalized, the lighter blue, and not hospitalized, the gray. So some patterns are clear. Who is dying in our state? The thickness of this deep blue part of the bar goes up, up, up with age, so that most of our deaths in the state are in those 60 plus. A substantial proportion of the hospitalizations, the lighter blue, are in 60 plus. But you'll notice there are plenty of people in the hospital who are in the younger age ranges. So when we say things like the elderly should be more older persons should be more careful at socially distancing, that's true. But this is an epidemic that has not spared any age group, particularly except for the very young. But there we're now worried about this multi-system inflammatory syndrome. And then last, we certainly look at how the epidemic is unfolding by racial and ethnic group. And unfortunately, I think everyone knows across the country, and I've said this repeatedly, pandemics thrive on inequality. And in our state, those who are African American in particular, but also the Hispanic population, have had higher rates of hospitalization and fatality. And this has certainly been an issue nationwide. So leaving a little bit of the basics of epidemiology, and just going to say a word about infectious disease epidemiology. Now, this picture may surprise some of you. This is a plot of the death rate from infectious diseases in the United States. Just for reference, penicillin came along in about 1950 for widespread use. And long before we had many of the vaccines and antibiotics that are so critical now, infectious disease mortality had dropped. And that was because we were generally healthier. We had basic hygiene introduced, better water quality, and food quality. So infectious diseases have been important. This spike should capture your attention. That's the famous 1918 flu epidemic. You might just see this little rise here, which is HIV AIDS. So we've certainly had pandemics in the past that have severely impacted mortality. And we're going to see a spike when this plot is extended out here to 2020. And just again, looking in the last 20 years, this century, we've had SARS, we've had the spread of Zika in new ways, we've had Ebola, we've had measles outbreaks, we've had MERS, and now we can add COVID-19 to this plot. The rise of these pandemics is, multifaceted. Certainly, they spread globally quickly because of our interconnectedness, because of air travel, because of our mobility at the global level. I mean, somebody can get on a plane infected in Hong Kong and quickly reach anywhere in the world. So with this and continued contact between man and the animal world, there's every potential for so-called zoonoses. These are infections jumping from animal to man to occur. I was in New Mexico in 1993 as head of pulmonary critical care medicine when we had the hantavirus, I'm sorry, this should say 1993, when we had the hantavirus outbreak. a disease that had been there before in retrospect, but again, one of those startling new outbreaks, and being right in the front line then was a remarkable experience. The other thing that's important for epidemic control is what is the route of transmission? And again, some basics. Fomite is a sort of a strange word, but it's the word we use for saying that there's transmission by infectious agents on surfaces, on objects, and we spread them by touch. In this epidemic, you've heard a lot about droplet transmission. That refers to the larger droplets we produce, larger particles we produce when we cough or sneeze. And those are the ones that don't travel very far. So the 6 feet distancing is to protect others from someone coughing, sneezing, or otherwise producing these large droplets, which on average are not going to make that beyond that 6-foot distance. One concern is how much transmission might there be by much smaller particles. People are using the word aerosol for those. And that is critical and still under investigation. Masks that we all should be wearing are to protect others against these larger droplets. And then herd immunity. There aren't many herd immunity cartoons, but I think I've got one. It says down here, Bob misunderstands the concept of herd immunity. Here's Bob surrounded by cows. Now, the idea of herd immunity is that enough of us are immune through having been infected or being vaccinated that the virus can't spread when an infected person comes in contact with someone else, because if that person is immune, the virus will not infect that individual. So we're a long way from having herd immunity with this infection, but clearly we want to get there. So let's move on now to the pandemic. I've given an awful lot of basics, and now I'm just going to give you a picture of where we are. Note, this is from June 5th. Of course, the size of the circle is proportional to the number of cases. You can clearly see what nation has the biggest circle, the United States. Unfortunately, the pandemic is rising in Brazil and is still growing there. You can see other countries. And, again, I'm sure many of you keeping up. For example, New Zealand has declared itself virus-free, having been completely isolated. Australia has had few cases. I worry a great deal about sub-Saharan Africa. I do a lot of work in East Africa, and I'm afraid if there were an explosive epidemic there with need for hospital care, mechanical ventilation, it would be very hard to meet. So that's the global picture. This is a nice picture showing the top 10 countries. This is a timeline showing the growth of the epidemic and its fall. So you can see where we are. This is back to January 22nd. Brazil, a little bit still in the hot zone. So the epidemic is still rising worldwide. You can see, for example, Italy, one of the early leaders, unfortunately, in having an explosive epidemic. So there's a picture globally. Here's the United States, reported cases. And again, of course, the New York area just lights up. Likely in part because of the density of people in that location, the extent of contact, the challenge of maintaining a high level of social distance. You can see some other locations, Detroit, of course, New Orleans, and here we are in Colorado. And hotspots in the United States, a lot of these hotspots relate to particular kinds of institutions, prisons, unfortunately, some of the meat packing and other facilities that you've read about, and of course, the long-term care facility outbreaks. And much of the burden is in these outbreak-prone areas that are so difficult to take on. Our top 10 states, luckily, Colorado is not among them. California persists, particularly the Los Angeles area with its high levels, again, shown by the color map up here. And we will be continuing to watch as this plays out. Now, we've already learned a lot, and we've learned the burden that affects so many in an equitable way. This is critical and I think perhaps inevitable in terms of who in our country is most able to effectively socially distance and who needs to continue to work, who has more spread out housing and so on. Talked about the long-term care facilities, the unequal burden by race, ethnicity, and socioeconomic status indicators, and then this problem of outbreaks that certainly we've experienced here in Colorado. The high-risk groups, this comes from CDC, older people, and again, these all has to do with our control strategies. How do we try and provide protective measures and policies for those who are older in long-term care facilities? We know that people with heart and lung disease, diabetes, likely with greater degrees of obesity, are also at risk. So when we start to think about our population, we start taking those 65 plus, say 20%, and then those in long-term care facilities, or with one of these conditions, we quickly realize that there are many people who are at risk from this pandemic. Here's rates of hospitalization. This is national data for the country. And you can see that the rate of hospitalization just goes straight up with age, quite similar to the data that I showed you for Colorado. The racial and ethnic disparities that I mentioned as well, again, rates for African Americans, Hispanic, Latinos, white, and Asian. This is in New York City. This is per 100,000. And again, not hospitalized, lab confirmed cases, non-fatal hospitalizations, and fatalities. And I think if you take Asian, for example, as your comparison, you go from 34.5 to almost 3 times higher in terms of the numbers of deaths. Now, this is Colorado data, and we're cutting here at the explanation for what I just showed you. This is an indicator, time spent at home for Coloradans by income group, going back to January and looking forward towards the end of May. So here we are in January, spending a lot of time at home. It gets a little bit warmer out, and just follow the solid lines. We're told to stay home and to be safe at home, and we did. Our time at home went up. Then mid-April, it began to drop off. Now, this is income group for the household, greater than 100,000, less than 25,000. So you can see that there was a great range of time, increasing time spent at home by income group. These are people who are in higher paying jobs and able to work from home. This is likely to include more service workers, unable to stay home, unable to give up income in order to be safe at home. And then here's the same by occupational categories. And not surprisingly, those in management, science, business, and arts, able to up their time at home across the early days of the stay-at-home measure. Those in construction, maintenance, still out working, and here's service workers in the green line. So I think we have insights from our societal structure into what drove who was most affected by these illnesses, by the illness. And then when you take a look at the top 10 outbreaks, correctional institutions, and meat processing facilities. And I think, again, probably most of you here are aware that there was an outbreak in the meat processing plant in Weld County. So we're confronted with an epidemic. How do we control? So let me talk through with you the tools that we have. So first, social distancing. Now, this is a word that no one was using a few months ago. It was not the idea. We like to mix, we like to mingle. A lot of our spaces are built so that we do that. At UC Denver, you have a great student center. That's so people get together. In bars, people are on top of each other so that they can get together. So certainly one of our tools is to reduce social distancing. For those of you who don't recognize this, and I'll forgive everybody under a certain age here, this is the cover of the Beatles album, Abbey Road. And you can see the Beatles socially distancing. At the time, they were alleged to be about to break up, and a great deal was made out of this. So social distancing, 6 feet, stay at home, don't open up Coors Field, and so on. Protecting the vulnerable. We talked about that and the need to protect those in older ages, for example, or with chronic illnesses. Case identification and isolation. So we do a lot of that. This is an example of spread on a bus, where you would want to know who was sitting here near a COVID carrier and who became infected. So identifying cases and isolating so they don't get on a bus and infect people. Contact tracing, which we're going to start soon. There's a lot of discussion about using new technologies to identify contacts. For now, I think in Colorado, we're going to start in the old-fashioned way with identifying cases and interviewing them about where they've been and who they've been in contact with for at least 15 minutes. And then, of course, masks. This is a great picture. This is, of course, our Governor Polis wearing his Colorado mask, greeting our Vice President, who you might notice is not wearing a mask. The governor has called for us to wear masks. The World Health Organization on Friday put out newly strengthened recommendations for wearing masks. Remember, this is a very simple, low-tech way to prevent infecting others. So this is about others, and again, it's an effective strategy if we all use it. I'm going to show you some data. The more we all do this, the better off we are. This is social distancing. This is the chairlifted A Basin from the webcam. We took this on the day that A Basin opened from their webcam. If you look, there's every other chair occupied. Okay, so I know A Basin is just closing up, but for the brief time it was open, they really did enforce social distancing and, of course, had a lottery system to limit how many people were there. And this is some scary episodes recently where there's obvious non-social distancing and every potential then for all these people in contact to spread the infection. Of course, this has come up with the protests, and there is concern that large numbers of people together do invite spread of the infection. So we're hitting the last leg here, and I'm going to talk to you about the mathematical modeling of infectious diseases. We're using models as an important tool to inform policy. It's our best way to predict what will happen. And as I'm going to tell you, we look back to what has happened, what has been the course of the epidemic in Colorado, and then they say what could happen. Shortly after the epidemic hit Colorado, we put together a team to work on modeling the epidemic to support the Colorado Department of Public Health and Environment and the governor in his office. This is our team that comes from multiple campuses. Jimmy Adams, of course, on the UC Denver campus. And this group has worked very hard to provide results in a timely way, sometimes across weekends, and late into the night to produce reports as needed. Now, what is the idea of a model? My colleague Beth Carlton uses this Picasso image to explain what are the elements of a model. And here we're taking this bull, and Picasso deconstructs the bull into the key elements of what makes that bull look like a bull in doing increasingly more simplistic um, models, lines. And what we do in a model is we build a statistical or mathematical representation of how nature works. And then we use that to look at what happens under different scenarios. So here's a very simple picture that I think we can all understand. So before the epidemic, we had not seen the SARS-CoV-2 virus. We were all susceptible. None of us had immunity. Then what happened? In this hypothetical epidemic, people became infected, and you can see the rise of the infection and the epidemic curve here. And over time, people who were infected recovered and moved on to this line. So in this simplistic representation of an epidemic, we have susceptible, we have the infected, and we have the recovered. Now remember, I said that it was key to know what the reproductive number is. And here you can see we have an epidemic and it drops because of whatever reason. So for Colorado, we're using a model very similar to this in spirit. We have susceptible individuals. We've added a box for those who are exposed. When people become infected, some are asymptomatic. That's one real problem with this SARS-CoV-2 virus. A substantial proportion of people don't have any symptoms, don't know they're infected, particularly at younger ages. And then, of course, some are infected, and then some need hospitalization, and some need hospitalization in an intensive care unit. And then, of course, some go on to die, and we try and minimize that and hope that most will recover. So in our so-called SEIR model, we build these boxes and the rates at which people move from one box to another, and apply that to the epidemic. So we can vary the degree of social distancing, how people behave by age, are they using masks, are we doing contact tracing, are we identifying and isolating cases. So this is the basic tool we're using. And then what do we find? So remember I said we look backwards to look at the behavior of the epidemic. What was the R value, for example? What happened over the months as we put control measures in place? And then we take the model and we project forward. What if we go from social distancing at some high level, so 80% reduction of our contacts, to 60%? So I'm going to show you pictures that address that. So what happened looking back, what will happen looking forward. Now we have a complicated story as we try and understand how all the different measures taken affected the epidemic in Colorado. So remember back to March as the epidemic emerges, remember ski resorts closing, the NBA season coming to a close. Remember stay at home, which went on longer in the Denver metro area than in Colorado, safer at home. And now, in the last few weeks, of course, there have been a number of reductions in the restrictions under which we're all living to keep the epidemic under control. We use hospitalizations as the index of the course of the epidemic. So here's Colorado hospitalizations through late May. This green line is just a statistical curve fit to the data. We think that right now we're doing well. This curve, this line is continuing to drop. That's good news. Then we can take that curve. And using our model, we can calculate the reproductive number, the R naught. Now remember, we want it below 1, that line. And now you can see where R naught was while we were having our epidemic and how it dropped as we stayed home. And for now, under safer at home, it's continued to stay below 1. So that's good news. Now, remember I talked about surveillance and tracking. So of course, we're continuing to watch that line. Okay. Now I'm going to show you a set of pictures. These get a little complicated and I'm going to explain it. So bear with me here. This is taking our model and now projecting forward. So this is how many ICU beds we would need under a specific scenario. The dotted line going across is about our capacity to treat people in the ICU with COVID-19, about 1,800 beds. This line just shows the middle of August when schools might be reopening. These curves are projections if we lighten up different measures back here on May 27th to go from probably 70, 75, 80% social distancing to 65, 55, 45, or at the end of June, we lighten up to 45%. Now, what we want to do is keep all these curves below our dotted line. Here you can see that the only one that stays below a white line, below the dotted line, is the white line, 65% social distancing. Now, why could the epidemic return when we've done such a good job of suppressing it? Well, the answer is that we are all still mostly immune. Maybe 3% of us have been infected, leaving 90% who could become infected. So that's with all ages doing the same thing. Now, what if we say to older people, say 60 plus, continue to stay with the safe at home measures, be largely socially distanced. Now you see the curves have flattened down. The red curve and the white curve stay below our dotted line. And the green and the orange don't go so far above. So clearly, strategies that urge those who are most vulnerable to maintain greater social distancing are helpful. And then finally, if half of the old people over 60 maintain social distancing, you can see that the curves go back up a bit because, of course, now we have fewer people who are protecting themselves at the highest level. So I put all the three curves together here. Everybody relaxing, there's distancing to the same degree, all people 60 plus maintaining a higher level, and half. So if you're a policy maker, you start to think, well, I have to have some strategies that may provide guidance to those who are most at risk to protect themselves more. And I think since I happen to be in this particular age group, I do know, I think that people in the older age groups are taking more steps to protect themselves and continuing to maintain a high level of social distancing. Here, I just want to show you mask wearing. And again, here's our mask wearing governor. This shows what happens if 80% of people wear masks. This is just one particular scenario, and I won't go into the details. But here's half the people wearing masks, 65% and 80%. One thing we actually don't know now is what percent of Coloradans are actually wearing masks, and it seems to be variable. I know that we spend most of our time in Boulder at the moment, very high level of mask wearing, and we go to Denver where we have a condo, we see much lower levels of mask wearing. So again, mask wearing helps, and it certainly doesn't hurt. So just to wind up, where are we going? So you notice that I've extended these epidemic curves out to November, the different scenarios. The answer is this epidemic will end if through some miracle, perhaps there's unexpected seasonality or other behavior of the virus, and we don't see it. I think that one is unlikely. Perhaps there'll be an unexpected summer lull. We don't know. But with most of us still not immune, it's a long way to herd immunity. Here's Bob again. Or with Dr. Anthony Fauci here, when will we have a vaccine? Well, the answer is there's a huge amount of work going on around vaccine development, as you know. When we have a vaccine, we still essentially have to vaccinate the world to truly bring the epidemic under control. So there's the development of the vaccine and then the extraordinary effort of delivering the vaccine. Remember, the one disease that we have eradicated, a viral disease, smallpox, we had had vaccination for a long time from Jenner, but it was the WHO's campaign to end smallpox, which required extraordinary logistics and planning that brought it to an end. So I think that is my last. I think I have a reading recommendation for you. The Great Influenza, a remarkably comprehensive book on the story of the 1918 flu. If you want to read a book about one of the world's truly catastrophic pandemics, turn back to this one. And last, Brown Bear of grandson Nicholas wearing his mask properly. So wear your masks and look forward to your questions. Thank you.
Dean Samet, thank you. That was really, really fascinating and generated several really interesting questions. So why don't we get to it with the time we have left? If an individual is hospitalized and dies, are they counted twice in the data? And I think this came in right after that blue graph. So did they wind up twice in that data?
The answer is no. Now, of course, there's been a lot of controversy about what is a death from COVID-19, and the couple points there. Death from COVID-19 is one in which COVID-19 is the underlying cause on a death certificate, and people who died infected with COVID-19, I'm sorry, with SARS-CoV-2, actually, who died while infected with the virus, but for whom that is not the underlying cause, are not counted as COVID-19 deaths. You may remember that CDPHE did some revisions a few weeks ago. That said, there are clearly an excess of deaths going on, and the excess is not fully explained by COVID-19. Some of this may be unidentified COVID-19. Some of this may be people failing to use healthcare in a timely way because they've been concerned about going to hospitals and emergency rooms because an epidemic was, in progress. So we do know that, for example, people seeking immediate care for heart attacks and strokes has dropped. So there's very complicated roots to having far more deaths than expected during this pandemic.
Okay, thank you. This was actually a question I had, but one of our participants also asked it. So what are the issues you've run into with getting an accurate number of cases, both from lack of testing and inaccurate testing?
Right. And so you'll notice that I said we're fitting our model to hospitalizations. Early on, we used cases, and now case counts, interpretation of them is very complicated. Of course, we've ramped up testing. And with the ramping up of testing, we know that case numbers will go up. So to try and sort out the course of the epidemic from both the course of the epidemic and the impact of testing together, we're relying on hospitalizations. Then that said, the problems around testing now are, and I think still getting sorted out, are with the antibody testing and trying to determine who has actually been infected. I haven't checked on this in a while, but a few weeks ago, the answer was that these tests were not very good yet.
All right. Is there a difference between crude death rate and death rate?
Okay. Come take epidemiology. So the crude death rate is simply the number of people in the numerator and the number of people in the number of people who have died, let's say. In the numerator, the number of people in the whole population, the denominator. It's called crude because no age adjustment has been made. And if you think about it, if you want to compare the death rate in, say, Denver to the death rate in a county with perhaps a younger age group, you'd want to take into account. So we're talking about age adjusting death rates. So crude just means we haven't taken age into account, or sex, or anything else.
Okay. How much is known about blood pressure and COVID risk? Are there any studies researching various blood pressure medications and COVID?
Well, sure. Okay, so the answer there has to do with the receptor that it binds to in the lung, the so-called ACE, the angiotensin converting enzyme 2 um, receptor. And this is a receptor type that is involved in the control of blood pressure. There's a whole class of drugs that binds to these receptors. And to my knowledge, and I will not claim to be up to date on the latest paper on this, so far being on these drugs seems to neither help nor harm those who are taking so-called ACE inhibitors.
Okay.
But it's interesting. It's an interesting pharmacological question for sure.
Are there differences between infection rates between inside and outside spaces?
I think the evidence I've seen in general, which is not surprising, is that infection rates outside are quite low compared to inside. There've been some scattered reports on this. It's what you would expect of course. I mean, people in smaller closed spaces, some contamination of surfaces, is far more likely to be spread of the virus.
Right. Let's see. I'm trying to think how to ask this question. Do you expect more cases than reported in kind of very poor areas and areas in places like Africa that don't have resources?
Yeah, so this is an important question. I mean, there are so many factors that affect the reporting of cases. I mean, just to start with the obvious, some are political, and just, I was reading a story that there was concern that there was suppression of the actual case numbers in Nicaragua. And Mexico, similarly, there's been a lot of discussion in Brazil. So there may be efforts to make what is happening in a country look better than it actually is. Access to care could be very, very important. Whether testing is available could be important. And in some countries, I mean, although all countries now are supposed to be registering deaths, not necessarily assigning a cause of death, death registration is still problematic. So certainly there could be epidemics in progress that are being poorly tracked. I know in speaking with my East African collaborators in 4 countries, Uganda, Ethiopia, Kenya, and Rwanda, they seem to be counting the cases in the big cities, and perhaps there's not spread so far out to the countryside, but in these very low resourced countries, epidemics could be catastrophic.
Yeah. This would connect to this actually in some ways. Do hot temperatures affect the rate of infection?
I wish I knew. I think there's been some work. There was a very quick review of this temperature and humidity by the National Academy of Sciences that I did not come up with anything conclusive. There's been a lot of work over the years on temperature, humidity, and influenza. I'm sure we'll see more papers. There's probably hundreds out there, given how rapidly things are being published, that may be relevant that I just simply don't know about. I think, and I know Jimmy Adams will be talking about misinformation next week. I'll put in a plug for Jimmy's talk because the flow of papers here is unprecedented, and they're appearing on these websites as initial reports without preprints, without going through peer review. And I think you've maybe read just in the last week, there have been retractions of two very prominent papers, one in Lancet and one in the New England Journal of Medicine. So, I can't remember, we're probably at 20,000 plus papers by now, and
Wow.
hard to track down.
Looking forward past fall, will we continue to see spikes until we have a vaccine? If so, do we have any idea how long it will take for herd immunity without a vaccine?
Well, let me take the latter first. I mean, I think the question is, can we get to herd immunity in a safe way? And that's really the tricky question. That's why those scenarios I showed you with the dotted horizontal line are useful for planning, because clearly we have to maintain enough distance to keep from having an epidemic we can't deal with our healthcare facilities. What does that mean? It means we're going to move towards herd immunity slowly. Right. Probably many of you have heard about Sweden, where there was not so intensive measures taken. There were many articles on this, quote, the Swedish experiment. I think last week there was a New York Times article about how Sweden now has, I think, the fifth highest death rate in Europe, and the epidemiologist who was an advocate for this strategy trying to say that perhaps it wasn't the right idea. The vaccine question, I mean, I'm not a vaccinologist, but I will suggest that even if we have a vaccine that is efficacious and safe, it's still going to take a long time to implement. So I don't know. I mean, I will wander way outside my expertise and say I don't think we have that vaccine, and I'm really starting to use it in a mass way for minimum of a year. But stay tuned. Stay tuned there.
Right. If a person tests positive for COVID-19, how long should they wait before getting tested again?
Test positive for the virus?
Yeah.
You know, I mean, I think that individual who tests positive, of course, would then be quarantined and should be isolated. And I think, 14 days, there's been a lot of discussion about whether some people who have either had persistent viral shedding or have had a second infection. I don't have the CDPHE or CDC recommendations sort of with me, even on whether retesting is warranted after a 14-day period. So that's one to look up at the website.
Okay. The WHO reported today that transmission from asymptomatic individuals is very rare. Is this what you're seeing in Colorado?
Well, I haven't seen what WHO said. I'd have to take a look, because I think, the concern has been that, in fact, transmission from individuals who are asymptomatic is a particularly problematic aspect of this virus. So I don't know what new data was driving that statement. We'll certainly look for it. Certainly in our model, we are allowing for transmission from asymptomatic individuals. We would have no data on that from Colorado. I mean, of course, the problem with transmission by asymptomatic individuals is,
how do you know? Right.
How do you know? So,
right.
And that's been one of the alleged challenges. But I'm fascinated to look and see what new data are driving WHO on this.
Yeah, I'm a historian of medicine, and one of the things I teach about is typhoid and asymptomatic carriers. Yeah, and it's how kind of those people can be marginalized in communities, actually, once they're discovered after the trace happens. Yeah. Has there been any update on the number of cases of patients who recover but with long-term or permanent damage to their lungs or related to blood clots?
It's a great question. And, I think there are really two things here. There's now emerging the idea that, in fact, we may be seeing people who are developing longer-term complications and fibrosis. I will say, and this is going back to my pulmonary clinical days, people who have had what's called adult respiratory distress syndrome, this sort of flooding of the lungs with fluid and inflammation, some of them do end up with damaged lungs, and this disruption of the architecture of the lung may lead to lasting changes. We don't have the follow-up studies yet that we need to say how many people that happen to and what is their course going to be. We do have such studies for this adult respiratory distress syndrome generally, and certainly many people recover, but not all do. The question of the small blood vessel disease, this identification of a problem of thrombosis of blood clots in the small vessels that seems to contribute to various features of the disease, I don't think we know about its course at this point. Clearly a sign of having more serious disease and this body-wide inflammation that seems to affect some people.
Right. Can you say a little bit about immunity once you've had the disease?
I think the answer is I wish I could.
Yeah.
I think this whole question of I think people have known to have developed neutralizing antibodies, the kind that would prevent a second infection from happening. But what we don't know is how long these will persist, of course. The purpose of vaccines is to engender the production of such of antibodies. However it's done, there are multiple mechanisms being evaluated. So I think we just don't know the long-term implications yet.
So how have the recent protests influenced your models for infection projections?
Yeah. So the answer, of course, is not yet. And let's take two questions to break this up into chunks. So the first piece would be, are the protests, large numbers of people coming together, situations under which viral transmission could happen? The answer, of course. And CDPHE has been using a figure of 1 in 300 Coloradans might be infected at any particular point. Whatever the number is, if 10,000 people are together, some are likely to be infected. And this is, of course, the circumstance where there could be spread. And, we've now had, I think, 10 days of protests, large crowds gathering. If there has been spread, if there's been enough spread to influence the course of the pandemic in Colorado, which I hope has not happened, we would start to see it roughly in the 2 to 3 week range after the crowds started coming together. So we haven't seen it yet. We don't directly incorporate particular events into our models. One issue is if we start to see the epidemic trend back up, we start to see that R naught rise 2 or 3 weeks from now, we'll have a lot of explanations, won't we? We'll have the protests, we'll have restaurants reopening, we'll have retail reopening. So lots of ways, lots of factors to take into account, and no model in reality could begin to separate those out.
Yeah. So I think final question, let's see. How have the models changed with such a long incubation period, kind of following on what you said, versus how much shorter the flu incubation period is?
Well, in a way, the models don't change. If we were building a flu model, we'd use a very similar tool that would incorporate the characteristics of influenza rather than those of the SARS-CoV-2 virus. I will say that our models over time have increasingly reflected Colorado data and Colorado numbers. And when we began this work, we didn't have the numbers we use now for Colorado. So we continually refine the model. We continually refit it to what is happening in Colorado. Right now, we're working on adding contact tracing, which has some of its own complexities. So the model continually is refined so we can better make projections. There's this famous quote from the British statistician George Box that I use all the time. All models are wrong, but some are useful. There are other models out there for Colorado. They don't all lead to the same conclusions because they are different. But I think right now we're pretty well tuned to what is going on in Colorado.
Well, thank you so much for this really informative session and leading us off for this series. I want to share screen for a second and let you see what's coming up. You'll see our next session next Monday is how to avoid misinterpreting data about an epidemic. Jimmy Adams, who Dr. Samet mentioned. We have a lot of very interesting social science, more science, that lots of different perspectives, a very interdisciplinary series. But I learned a lot with this about the modeling. Really interesting. And I have to say, it still makes me want to be very careful. So if that was your message kind of coming out of this, it was successful. So thank you very much.
Okay, delighted to be with everybody.
Huh?
Happy to have done this. Thank you.
Yes. Oh, great. All right. And hopefully we'll see everybody next week. Thank you.